Respected chairpersons, friends, today I am going to speak on the topic how to enhance visualization, or in fact the theme of the topic is how to do cataract surgery in the cloudy cases or the cloudy corneas. There is no financial interest in it. So why? First of all, why we need something extra or we have to do something extra? We often see such type of conditions in our OPD or that is where these patients came to us, all of us, for the cataract surgeries. Now it's okay. Okay. So we have to know that these patients are coming up and we have to do something which is different from the normal routine cataract surgery in all the aspects, either taking care of the I will power calculation or the visualization or having slight change in our uh, procedure what we are going to do. So what happens? First of all, the pre-operative planning is required for such cases. We have to know what are the existing pathologies and also look for if there is any active infections which has been subside at least for the 3 months for that. One of the important thing is to calculate how to accurately measure the axial length or the do the I will power calculation. So axial length calculation is slightly difficult in such cases because of these corneals opacities are having different corneal thicknesses and may lead to the irregular corneas which have a indentation problem with that. So what are the alternatives? It is not a when we are doing with one or two, then there are the few alternatives which guide us that yes, by this method or by that method we can measure more accurately. One is the immersion ultrasound USG, means when you are going with the contact A scan, shift to the immersion. Another one we can also use the video keratography for that. And when we are going, it's not only the contraindication, just a precaution, means if you are planning such a surgery in which cornea is opaque and you are planning for the cataract surgery, always advise to look or work how is your the posterior chamber, because it's not only the cornea is involved, sometimes you have a multiple issues. Cornea is involved, then there is cataract, and because of these cornea and cataract, it's difficult to have idea about the posterior capsule posterior segment anomalies. So go for that and look how we can modify it. Coming to the some surgical tips how we can do, just ma'am showed wonderful videos with age scan. That one of the important thing is which side we go or plan your surgery. It is if you are looking for here means opacity is this way, so better is plan your incision in the area where you can visualize cornea good in a good manner or the cornea is visualized comfortably. And second thing, start your CCC, means whatever you are going to plan your rexis, again start with the visualized area, so that once you started with your area means at your visualization, you can go slowly and you can have a better movement of adaptation, or you can plan it in a better way if you start from this area. Again, there are various techniques I am going to show you in later slide how to improve the visualization or do in such a cloudy conditions. One thing, we can use dyes to stain the capsular axis just for the benefit of the better visualization. One more thing, if we are going to plan a phaco surgery, for that we can go our plans in a such a way that you can go for a primary chopping technique, or for that again it's in the visualized area. If grade is higher or cataract is of harder grade, then we can also plan good alternative is SICS. Our executive chairman of ISMICS, Dr. Boramani, is here. He will tell you more updates about the last talk in how this manual small incision cataract surgery will help us in removing this or planning cataract surgery in cases where SICS is where we can have a difficulty in doing phaco, but SICS you can perform well. Again, I am not going in detail, but one thing we have to know regarding the aspiration of the cortical matter. One thing is required, that you have to perform it either by the retroillumination method, or you have to in the retroillumination view, or something again advice is to hydrate in the area where your visibility is poor, so that it's just a sloughing material, it comes out and you can then aspirate. Now coming to the methods of the illumination which we can plan much better. In all the most of the microscopes we have two types of illumination system. One is paraxial, another is coaxial. What happens when we are going for this paraxial view, then there is more worsening of or scattering of the light from the back. So it is advisable to use a coaxial view, so that there will be less scattering and we see in the corneas better. Another one is intracameral illumination. This we can do with the help of a smaller gauge pipe with using vitrectomy pipe, or nowadays FDA has approved one eye chopper which itself is having an illumination system. So when you are chopping, its light move, it is having the light source and it divides into two, then visualization is slightly better than a non-illuminated chopper. Another method to increase visualization is the intravitreal central illumination. Here what you can do, you just simply put a vitrectomy pipe inserted inside the vitreous cavity and you see the retroillumination techniques with the help of it. But yes, this technique requires something for the if anterior segment surgeon is performing with this technique, then he or she may have some knowledge how to put or comfortable with these endo illuminators, or you can take the help of any vitreoretinal surgeon for this method. Again, just like a torchlight examination, there is an oblique view of external illumination in which you just show the light of these endo illuminators on the limbus. So if light is on the one side of limbus, you know that cornea itself behave as a lens particle and half of the part is illuminated to the another side. By this method you can see whatever is the possible, but major drawback for this method is that this technique involves something in which someone has to hold the light continuously during the surgery at the limbus. There are other methods in which by any means it is not possible to do cataract surgery because of opacity is more or such a higher grade. Then in that way we can shift our techniques or perform a combined technique in which we can do corneal and the cataract surgery both at a time. This is the flowchart adapted from the article published by Dr. Namrata Sharma in Journal of Cataract and Refractive Surgery. Here you have seen, if cataract opacity is such that is minimum, that we can small cataracts opacity, then we can perform the cataract surgery alone. If these opacities coming to the visual axis, then slightly plan an optical iridectomy. By this we can increase the method, means we can increase the pupillary diameter, and now this cataract is seen beyond the opacity and we can go for that. But if it is so opaque that it's not possible, then again we can go for the cataract with the keratoplasty or whatever the different options available for us. So even we can go for the triple procedure simultaneously just to increase the visualization and do it. Now the final takeaway, whatever is important, first have a careful planning. Means if you are going to treat or operate on such a patient which is having a cloudy situation, requires more planning. Just give me one, which last slide. Better planning. More than that is the realistic expectation from the surgeon side, and also explain your patient that it is not a routine cataract surgery where anyone can give 20/20 or anything. This is a cataract surgery, means part of your vision is lost either because of the opacity or some the fundus problem. I am treating only for the cataract, so there is nothing change in that. And last one is, whatever the various methods available at your center, plan according to it. Thank you. If any question.